great to be here this evening. I also want to thank the Lung Health Foundation for setting this up. And Lung Cancer Canada, we do enjoy working quite closely with the Lung Health Foundation, and any opportunity to talk about my favorite topic, which is lung cancer, I'm always pleased to do so. So it's a pretty big topic, and I've got about 45 minutes because I want to leave time for questions. I'm pretty flexible. I've also got the chat and the Q&A open, so I can keep that open and keep an eye on that as well as I'm going through. But if you have a question, don't hesitate to speak up. You won't throw me off my rhythm or anything, because I think this is a great topic for our primary care providers. So here we go. So these are my disclosures, none of which have anything to do with what I'm going to talk about this evening. And our learning objectives this evening are fourfold. So we're going to talk about recognizing the clinical presentation of lung cancer. So what a patient may actually come in with their chief complaint or things that you may pick up on history. And then we're going to talk about those patients who are asymptomatic and maybe candidates for lung cancer screening, because we are slowly but surely rolling out our programs for screening for lung cancer across Canada. We're going to talk a little bit about the diagnostic workup for a patient who has a suspected or confirmed lung cancer. And then finally, I really hope to be able to place lung cancer in our patients in a socioeconomic context, because the experience of having lung cancer is very unique compared to many other cancers. And we have to look at the whole patient in order to make sure they have the best outcomes and access to care possible. So starting with a little bit of background. Some quick facts. Lung cancer is an incredibly relevant cancer in Canada. It's the #1 most commonly diagnosed cancer, and it is the #1 cause of cancer deaths. In fact, 1 in 4 cancer deaths are lung cancer, and that's more than breast, prostate, and colorectal cancers combined. About 1 in 15 patients will be diagnosed with lung cancer during their lifetime. And right now, about 70% of new diagnoses are either stage 3, which are very local, regionally advanced, or stage 4, where there's metastatic disease. And that's part of the reason why we see such a large mortality impact and poor outcomes for this population, because by the time these patients are developing symptoms and coming to the system, they often are quite advanced. So based on just how common this cancer is, you will see lung cancer in your primary care practice. So hopefully some of the things we'll talk about this evening will help you with an approach with these patients. Now, those are some pretty dismal stats. So things are overall getting better. The Canadian Cancer Society did a special report on lung cancer in 2020. And what we saw there was that the 5-year survival, all types of lung cancer, all stages, had come up over 5% compared to the early 1990s. And at that time, the calculated 5-year survival was 19%. Now we see it depends on what kind of cancer you have. And in general, the green bars, which are female patients, are doing better. But we saw even better statistics the next year with the general Canadian Cancer Statistics Report. We crossed the 20% threshold for the first time for a predicted 5-year survival. All types of lung cancer, all stages, so 22%. So we were very happy about that, but you can still see how far below the survival curve is for lung cancer compared to those on the top, which of course are very top: breast and prostate. And then the lighter blue hash is colorectal cancer. So we've still got a long way to go. Now, so far, what's been driving this success in Canada has largely been our newer therapies in advanced or incurable lung cancer. So we can see that the average survival for somebody with incurable lung cancer on the far left here with chemotherapy used to be less than a year. And then as we developed newer therapies, including immunotherapy, so that's an example of this anti-PD-L1, we definitely increase survival. And then those highest bars, especially most notable, the blue on the far right, those are patients who have an identifiable driver mutation at a molecular level for whom we can give them targeted therapies. And that tall bar, that kind of tealy blue with the 19-month survival, that's a particular mutation called ALK, where if patients get a sequence of the different targeted therapies, they can sometimes live into the double digits of years. So really changing things at that level. However, we're going to talk a lot about screening tonight. We really hope that's going to be the next frontier, is picking up patients when they're asymptomatic and their cancers are very small and early stage, and we can treat them with local modalities, especially surgery, for cure. So For those patients who are actually presenting with symptoms, which unfortunately still is how most of our patients in Canada do present, what does this patient look like? So here we see the incidence rate of cancers broken down by age. And you'll see I've circled here the lung cancer cases with those red circles. And we see that most of the incident cases are in patients who are older. So those three groups there are starting ages 50 to 69, 70 to 84, and 85 plus. So this is not typically something you're going to think about as a common presentation with a cancer in our younger population. That being said, a lot of our lung cancer patients are still young. And while the incidence here, when you look, for instance, at 30 to 49, you really got to look really hard and kind of squint to see that 3% of lung cancer. We do see them. Here we go. We do see them represented here in 9% of the cancer deaths by group. So definitely in that age group that's 50 plus, we are seeing that it's the most common cause of cancer death. But even our younger patients, 30 to 49, it's the third most common. I know I have another slide there. I was going to go back to that one. So another really key point is most of us will associate lung cancer with tobacco, and that certainly is the biggest risk factor. But you should never assume that the patient who's a never smoker doesn't have lung cancer, because more than 1 in 5 of our lung cancer patients have never used tobacco products. And in fact, if you took out all the tobacco-related lung cancers, this would still be the 5th most common cancer in Canada. So a real take-home message is anybody can get lung cancer. And really the only risk factor for getting lung cancer is having lungs. And it's the never smokers who are those who are actually more commonly presenting at that younger age. And I've seen patients as young as their young 20s, definitely patients in their 30s and 40s. And those are definitely more likely to be our never smokers. So in terms of some of the presentations, the symptoms depend on where the cancer is. So most commonly, patients will have local symptoms, so related to the tumor in their lung itself. Definitely the most common would be a cough or persistent cough that just won't go away, or dyspnea, shortness of breath. And of course, because a lot of these patients do have a significant tobacco history and have the comorbidity of COPD, those may be baseline. So what you're looking for in those patients is a worsening. Some patients will actually have chest pain as well, depending on where their tumor is, or they might be presenting coughing up blood, either streaks in the sputum or just bright red blood or clots in and of itself. Now, some really important things to pick up on history that should never be missed in terms of local symptoms include a new hoarse voice that's persistent, and especially someone's like got a really hoarse voice, like they've totally lost it. If you're seeing extremity of the upper extremity swelling, along with prominent neck, chest, or head veins, like really dilated, or little collaterals growing in a Horner syndrome. And I've got a couple of images to explain why that is coming up. Now, in terms of some of the other symptoms of local disease, patients may also have wheezing. Now, if their cancer spread, that can also be their presenting symptoms. So lung cancer in general likes to spread to the brain, the bone, the liver, the adrenal glands, and actually the other lung is a common site of metastases as well. So patients who have bone metastases often have a lot of pain, so they might come in complaining of that. CNS metastases, depending on what part of the brain is involved, they may have headaches or vision changes. Some patients actually have deficits, a sensory or motor deficit, or seizures. And even though it's more rare, I definitely have seen people with personality changes, and sometimes they're brought in and their partner might just say, I wonder if they're getting, some dementia, their personality is changing, they can't focus, they can't do short-term tasks, and they actually end up with widespread brain metastases. And the liver being another common area, it's very, very common for patients with liver metastases to have lost their appetite. They also may have early satiety if they've got bulky lesions in the liver, or nausea, and they can actually have liver pain. And that gets exacerbated when they take a deep breath or when they bend over. It's a very compressive type of pain. And it's because the enlarged inflamed liver, it kind of touches off that hepatic capsule, and that's very sensitive indeed. And then finally, there's the constitutional symptoms. I put here in all caps weight loss. Weight loss is very, very common in this population, so that should definitely be a red flag. And I have some patients who are like, oh, I decided to take a diet and, exercise to try to, lose some weight. And all of a sudden 50 pounds just fell off. And certainly primary care providers know what a challenge it is for many people who do want to lose weight and follow a more healthy lifestyle to achieve that. They really struggle. And so for 50 pounds just to fall off, that's usually a pretty big red flag. And almost all of my patients, when you directly ask them, have lost weight. A lot of them also will be complaining of fatigue, and especially those with faster growing or more aggressive cancers will have those B symptoms that we sometimes associate with things like lymphoma, but drenching night sweats can be a common one as well. So in terms of some of those special clinical presentations that I've got some pictures to go with, we're going to start with Horner's. So Horner's syndrome is typically seen with tumors that are in the upper fields of the lung, so the upper left or right lobes. And here we see an MRI picture where this Pancoast tumor, which is just a colloquial term for these upper lobe advanced tumors, you can see is actually invading into that vertebrae. And another thing that these will commonly do is invade into the brachial plexus. And so patients with Pancoast tumors have very specific symptoms. They have horrible pain, almost all of them. It's shoulder pain and arm pain, and it's very severe, and it's often got a neuropathic quality to it, very difficult to control with just opioids. They often will also have paresthesias and paresis of that upper extremity, and they can, because they've lost their nerve functions being compressed, they can actually get the atrophy in the thenar muscles in the hand. And so that's often the direct invasion to the brachial plexus. Now, in the brachial plexus, we also have sympathetic nerves that are actually going up into our face. So that's why we're getting this Horner syndrome. So Horner syndrome is the triad of ptosis, meiosis, and anhidrosis. So here's some pictures. So here's a lady, and it's her right eye that's being impacted by the Horner syndrome. So you notice that that right eye is not as open as much. So there you've got the ptosis, and the pupil is smaller as well. Now, here's another lady with the same thing on the right side. But interestingly here, she's also got a really kind of unique finding called Harlequin sign. And so you can see that she's quite pale on the right, but her left side of her face is kind of flushed. And that's the anhidrosis. And so what's happened is that these patients can't sweat and flush because they've lost that sympathetic innervation on the same side. So if they physically exert themselves, like if this lady finished her aerobics, you get this almost straight demarcation right down the half of the face where one side can appropriately dilate the blood vessels and sweat and the other one can't. So those are the classic findings for Horner syndrome. And of course, Horner syndrome doesn't necessarily have to be a lung cancer. There's other things that can compress those nerves, but definitely something to think about if you have a patient with that presentation. Now, SVC compression, this is the swelling of the upper extremity. So if the superior vena cava gets obstructed by the tumor, the upper extremities especially can't drain their blood. The face also gets quite plethoric and kind of ruddy looking. The neck often fills in a lot. And depending on the chronicity of how long this compression developed, you can actually see a lot of collateral blood vessels developing on the chest. But if it happens very quickly, it's just very, very dilated blood vessels, almost like varicose veins on the chest and on the arm. And one of the ways to test if that's why a patient does have swelling is you can see the schematic of the patient here. He's got his arm up in the air, but the veins will not empty because there's nowhere for them to drain. And this is generally considered to be one of the oncology emergencies. But because this can happen slowly and subtly, a patient might present, and just you notice that the blood vessels or the swelling yourself on a physical examination before they're actually even complaining, especially in a non-small cell lung cancer, which is a slower grower. Recurrent laryngeal nerve paralysis. So this is your patient with the persistently hoarse voice, the person that thought they had laryngitis and their voice didn't come back. And the other thing to think about is if they're aspirating, if they're no longer protecting their airway, especially when they're drinking fluids or fluids going the wrong way a lot. And that's because our laryngeal nerves go down from our cervical spinal cord, and they go all the way down to the mediastinum. And you'll see, especially the left recurrent laryngeal nerve, it actually loops underneath the aortic arch here, and then they track back up the trachea where they innervate the larynx. And so if a patient has bulky mediastinal lymph nodes, they'll actually ping out those nerves when they're coming down, especially that left one, because there's all kinds of juicy lymph nodes right there at the carina and in the periaortic area. And that is actually one of the criteria to determine if the patient is inoperable, if they have this recurrent laryngeal nerve paralysis. Now, the loss of the voice and the protection of the airway can actually be very problematic for patients. And I had a lovely lady, and she had 3 sisters who lived in Newfoundland, and she loved talking to them on the phone. And she had an incurable cancer. Not being able to speak was really causing her a lot of distress. So we have a great ENT surgeon at our center, and we only have one because we're a small province. But what they can do in ENT is they do direct visualization of the vocal cord, and they see which side is paralyzed. And then they just do some freezing on the neck, and they directly inject it. It's kind of like a filler, the kind of things that people will often use for like cosmetic surgery to plump up lips. And that brings that paralyzed nerve right to mid. And then the other one that works is working great. So then they actually get their voice back essentially immediately. And it's a great palliative maneuver that patients can get a lot of benefit from. So keep that in mind if you have a patient who does develop this for any reason, but most notably from lung cancer. Now, clubbing is something that all of us have seen and can recognize, but clubbing in lung cancer often can go along with another entity called hypertrophic osteoarthropathy. And that is a very extensive, so here we got the classic clubbing. So we all remember that from med school, the 5 signs of clubbing on physical examination: the thickened fingers, the loss of the nail bed, the sponginess. But in the hypertrophic pulmonary osteoarthropathy, they get inflammation. It's often of the long bones and very commonly of the shins. So this is a picture from a bone scan. You can see just how much inflammation is involved here. And even on plain x-rays, you'll often see periosteal thickening. And that's the inflammation. And this is not spread of the cancer. These are not bone metastases. This is a paraneoplastic phenomenon. And whatever it is, it's the same mechanism by which people get clubbing. And so I actually had a lady who was one of my lung cancer patients, and she presented in the summertime with this horrible, horrible leg pain. Her legs were so exquisitely sensitive, you couldn't even touch them. And one of the noted features of this pain is it's resistant to most analgesics. So really high dose of opioids didn't touch her, anti-inflammatories, a trial of steroids, gabapentinoids, nothing really worked. But like many other paraneoplastic syndromes, if we just treat the cancer, it will get better. And so if you do have a patient who's presenting with really out of proportion pain, symmetrically involving this kind of distribution, and they have some other risk factors for lung cancer, especially if they've got clubbing, you should definitely think about lung cancer. And it doesn't necessarily mean a diffuse lung cancer. Localized lung cancers can also cause this presentation. And then finally, some other neoplastic things, paraneoplastic things. So paraneoplastic just really means any symptom that's not directly caused by the tumor bulk itself. And so lung cancers can be quite notorious for secreting all kinds of antibodies and different chemicals that can kind of play havoc with many different systems. So a lot of these may end up having electrolyte imbalances. So SIADH with the low sodium is a very classic lung cancer issue. And of course, as you will all recall, SIADH is not a problem of not enough salt. So unfortunately, eating potato chips doesn't fix these patients. It's a problem of inappropriate retention of fluid at the level of the kidney. And so volume restriction will generally control this until ultimately we can get their cancer treated. Hypercalcemia of malignancy is quite commonly seen in lung cancer as well, and that can be quite profoundly symptomatic. Patients can be very constipated and dehydrated because their kidneys trying to pee out all this extra calcium, but it can actually lead to mentation changes and even comas. So definitely one to think about if you have a patient presenting with hypercalcemia. Now, more rarely, thankfully, but very dramatically, some lung cancers can make different hormonally active chemicals that act like aldosterone or ACTH. So these patients will typically come in with a profoundly low potassium. I've seen potassium is less than 2 in the setting of actually a high or high normal sodium. They often have a lot of peripheral edema and a very high blood pressure. And again, the treatment here is to treat the underlying cancer, but that usually has to be done in hospital. And they need really, really high doses of replacement potassium just to try to keep them in a safe level. Paraneoplastic syndromes can be all kinds of crazy neurologic things. So anything neurologic can pretty much be a paraneoplastic syndrome. The classic one we think often is the Lambert-Eaton with the kind of stocking glove. We've got cerebellar issues, those sensory, even encephalomyelitis, retinopathy. So there's a lot of antibodies that these cancers can make that would be a neurologic presentation. And finally, some more general ones. Hypotension, lung cancer is a state of inflammation in the body. So a patient who previously required multiple antihypertensives to control their blood pressure might be coming in, have a lot of pre-syncopal feelings or even syncope and their blood pressure is low. And that might be a sign of an underlying cancer. And then definitely hypercoagulability. A lot of patients can present first presentation with something like a DVT or a pulmonary embolus. So in terms of the diagnostic workup, the key thing is if you suspect lung cancer in a patient with symptoms, usually the easiest test to get is a chest x-ray. And if you actually have an abnormal chest x-ray, that's usually a way to get access to a CT scan of the chest, which is really the test that you're after. Because unless you live in a very different healthcare system than we do in Nova Scotia, I can't get a CT. Well, I can, but a primary care provider usually can't get a CT within a couple of days. But a chest x-ray can often buy you that way. The key thing is, if your patient does have persistent or concerning symptoms and the chest x-ray is normal, don't stop there. I've seen some people get a chest x-ray and it was normal, but a lot of things can hide behind the mediastinum and the sternum. So if the patient, you're worried about them, it's really important to still advocate that they get a chest CT. And you may need to refer to a lung specialist simultaneously, a thoracic surgeon or a respirologist to help you out with that, depending on how easy it is for you to get a CAT scan locally. It's always a good idea when you think a patient may have lung cancer to start off getting some baseline blood work at the same time, because we've talked about so many of these paraneoplastic issues can cause issues, including sodium and calcium, and also just to get a sense of their liver and kidney function. If liver enzymes are through the roof, that's a good sign that they may have liver metastases, and a CBC can often give you hints as well. Now, once you get to the point where you've got a patient with a suspicious finding on a CAT scan, at that point in time, generally you're moving to a referral to a lung cancer diagnostic expert. And it was specifically vague because who that doctor is different depending on where you live. Here in Nova Scotia, almost all of our suspected lung cancers go through our thoracic surgeons, but it's quite common in other provinces that respirologists or pulmonologists are really spearheading this whole process. Now, there's some centers, for instance, in Ottawa that have amazing lung diagnostic programs to which you can refer. It's kind of like a machine that just runs, and they have great administrative support, nurse administrators who make sure that there's coordination of all the different tests. But really what you want to do is get this patient in with somebody who's used to doing this is what we do every day, is kind of run the patient through the system. Now, in an ideal world, there will be provincial unique diagnostic pathways that are linked to universal EMRs. I don't think any province is close to that. Here in Nova Scotia, they've been promising us our one patient, one record, where primary care providers will use the same EMR as all the hospitals. And of course, the pharmacists and everyone will have access. And we know it's coming. I'm not holding my breath though, but we're already working on our lung cancer diagnostic pathway. So it's under construction. And you're not supposed to be able to read this. But that's just to give you a general sense of the algorithm that we're working on. And our working group has members right from the community level with patients, but we've got primary care providers, all the different specialists, nursing and pharmacy involved. And in an ideal world, a primary care doctor will be able to click on this and say, I think this patient has lung cancer, and it will tell them what investigations and referrals, and a simple click will give them the link to the referral, the requisition, and hopefully that's how the whole world will run someday, but I don't think we're quite there yet. So in terms of staging tests, most of this is generally going to be done by either that pulmonologist, respirologist, or thoracic surgeon. But in terms of the CT scan, we need to get a CT scan of the chest with contrast if at all possible, because that gives us really good delineation of the anatomy. And we might as well throw in the upper abdomen, because right off the bat, you'll get a sense if there's adrenal or liver metastases. Now, otherwise, for staging, a PET scan is the gold standard if it is accessible. In some centers, it's more accessible than others. Bone scans we traditionally did if a patient had bony symptoms, but you don't have to bother to check out their bones if they don't have symptoms. And if they've had a PET scan, that should have covered their bones. Unless it's very distal, like for instance, our PET scanner just kind of goes down to the knees, but distal bony metastases are actually quite rare. They're usually more proximal long bones like the humerus or the femur or the spine or along the actual pelvic bones. Now, best staging for the brain is an MRI. But again, if you guys are working in a healthcare system, anything like mine, it's hard to get MRIs. And some people, MRIs are contraindicated. And so CT would be the next best. Now, in terms of who needs their brain image, it's really for patients who have stage 3 cancer or if they have symptoms. So not everybody needs to have a brain imaging done, but if they do, it's best to go with the gold standard brain MRI. And we've been moving more and more, especially over the past 2 months, now that we have access to neoadjuvant or induction treatment with a combination of chemotherapy and immunotherapy for patients who have resectable disease, right from stage 1B through to 3A. So pretty much the whole gamut of what might be resectable. And all of these patients, there is an indication for surgical staging of the mediastinum. And that's done with this process called EBUS. So it's an endobronchial ultrasound. And that's generally done by a respirologist or a thoracic surgeon. So that often will give us our tissue diagnosis. We also want to know someone's molecular mutation results. We talked about those driver mutations earlier, and that can actually influence the decisions that we make for that neoadjuvant or induction treatment. So we do want that tissue up front. And if for some reason someone is not getting an EBUS or doesn't have access to an EBUS, often they will get tissue using a CT guided biopsy. But these days at our center, I've actually found that people who are being sent for CT guided biopsies, I mean, it's more demand on the system. There's some risk to getting that biopsy done, and then they have to get an EBUS anyway. So it's almost like another step that didn't need to happen. And it's very important if they are current tobacco users to start the conversation about smoking cessation right away. Regardless of the stage, if they're going to be treated with curative intent or palliative intent, patients that are able to quit smoking will have better outcomes. And we definitely know that patients who are active tobacco users will have lower efficacy from systemic therapy, radiation. And if ultimately they're going to the OR for a big lung surgeon, the sooner we can get them healing their lungs and healing those little ciliates so that they're less likely to get a postoperative pneumonia or difficulty weaning from the vent, the better. So now moving on to screening. Hopefully with screening, you guys will need to think a lot less about identifying patients presenting with symptoms and what's the diagnostic workup and who do I refer to, because we do know that lung cancer screening saves lives and it definitely reduces lung cancer specific mortality. And that's because a small 1 or 2 centimeter stage 1 cancer, especially non-small cell lung cancer, it can be there for quite a long time before patients become symptomatic and it progresses to the point where it would be amenable to cure. So our goal is to pick these tumors up when they're early so they can actually get a surgery or curative intent radiation. So risk factors for developing lung cancer. Definitely we know that most lung cancer cases are related to tobacco. And unfortunately, during the COVID-19 pandemic, tobacco sales went up for the first time in a very long time. And I think we all know what the stress and the isolation and the mental health issues that came along with COVID for many people. And I think that really drove a lot of this increased tobacco use. We also know that secondhand smoke exposure, especially people who worked in environments like restaurants or bars back before we banned smoking from those areas, did have a major impact on their cardiovascular and lung health. But certainly that's not the entire story. Especially globally, we know a lot of lung cancer is related to the breathing in of fine particulate matter from pollution. And especially in Asia, a lot of use of solid fuels for cooking. So these coal kind of stoves and ovens that women are using for cooking in China, that in very poorly ventilated homes, and bringing in that smoke constantly, it's really driving lung cancer in females in Asia, to the point where in Taiwan, women have a higher risk based on their cooking history than their actual tobacco history. And there are certainly other risk factors. There's other occupational exposures, things like diesel fumes, mining, asbestos, other inhaled chemicals. And asbestos is a big one if people were not only doing mining, but also doing construction or like boat building, that type of thing. Radon is a big risk that we really don't fully understand because it hasn't been overly studied, but it's an odorless gas that comes up out of the ground, and it can be found in your home. And definitely here in Nova Scotia, we have some hotbeds. And if you don't test for it, you don't know you've got it. And just this year, since 2023, I've had two lovely new patients, both less than 40, both mothers with several children, no risk factors, coming in with stage 4 lung cancer. And when they actually tested their homes, they had very high levels of radon. There's other things that also predict a risk for lung cancer: a personal history of a different cancer, or there may be some genetic links. We're just beginning to understand that literature and that research now for a family history. And then there's some socioeconomic things. People coming from lower income families, poor living conditions, people who are homeless are definitely at higher risk. And finally, there's a whole new generation now of legally inhaled things that should not be going into our lungs as foreign objects, including cannabis and e-cigarettes. And really, the only group that should ever be using those vapes or e-cigarettes are people who cannot otherwise quit smoking. Now, we don't know the long-term health issues of using vaporized vaped and e-cigarettes, but we definitely know the long-term risks of smoking tobacco. So if you've got a 50 or 60-year-old person, they just cannot quit smoking, but they're able to give it up by inhaling, using those vaporizers, that's actually probably okay. Unfortunately, the vaporizers are not being targeted towards that population. They're being targeted towards young people. They're all like cotton candy and bubble gum, and it's really cool in high school at these young populations. And it's really quite sad. The vaporizing companies are all owned by the tobacco companies, and they're setting them up such a strong tobacco addiction that they're setting up a whole new generation of people. If they have one cigarette, they'll probably become addicted, and in and of itself, they have a market. So these are other things to think about. So the screening test is a low dose CT. There's no need for IV contrast in a low dose CT, and the actual level of radiation is 4 times less that of a traditional CAT scan. Now, I have another slide on some of the side effects, but really the risk of having radiation exposure for a screening test is based on how old you are, because there's a huge time lag. So if we're talking about screening children or teenagers or 20-year-olds, well, that actually puts them at huge risk for developing cancer much later in life. But when we're talking about screening somebody in their 60s or their 70s, the impact of the danger of that radiation wouldn't really kick in until they were like 110 or 120. So we're probably pretty safe for those patients. This is the only test that's recommended for a screening test. There's no evidence, and it has been studied for chest x-rays. So it really is the low dose CT. Now, this is based on a number of trials now. These are the 3 biggest ones. The National Lung Cancer Screening Study, the NSLT, that was the first one that came out of the US. And we can see they looked at patients 55 to 74, and they defined the risk based on tobacco use. And they did 3 annual scans, and they found that lung cancer mortality is reduced by 20% with a hazard ratio of 0.8, but all-cause mortality was also reduced. The Nelson trial was a huge trial done in Europe, and this lowered the age to 50 and had some different tobacco use criteria. And this extended out to 4 scans, and this went over 5 years. And this found an even further risk reduction for lung cancer mortality, especially for women. Hazard ratio there of 0.67, so 33% reduced. And the MILES study looked up to 10 years of screening and really lowering down the age range here, starting at 49 to 75. And this is where we saw the biggest benefit: a hazard ratio of 0.61 for lung cancer mortality, but also 20% reduction in all-cause mortality. So when you put all the screening studies together, we see that in this meta-analysis, the overall reduction in lung cancer mortality is 0.846 or 16% reduction. So definitely saving lives by picking these up at an early stage. Now, this is an older slide. Now, this is from 2 Octobers ago, but at least we had some CPAC, the Canadian, oh gosh, I'm blanking. CPAC, the national group that provides support for cancer. I can't remember what the P is, but anyway, it's the Canadian Something Against Cancer. So they had different pilots across the country. And since then, we've actually had rollout of some official programs, but they're not readily available for all Canadians by any means. So in Ontario, you do have a program that was implemented in 4 sites in March 2021, but that probably doesn't apply to all the patients, certainly not in Northern Ontario. Now, British Columbia has their program implemented, and Quebec had a pilot, and then they've got a smaller program, but right now it's being threatened to be actually shut down. And so we're doing a lot of work advocating to try to keep that open. And Alberta's the most recent. They ran theirs out in September, but they're limiting it to 3,000 Albertans, and then they're going to reassess. So you can see that the eligibility age group across provinces is a little bit different. Alberta goes down to 50. And the way that they define who gets screened is based on their 6-year lung cancer risk. And you can see there's a bit of a variable risk, but pretty much 1.5% or 2% risk calculated over the next 6 years. So how do they calculate it? They use this PLCOM 2012. So this comes from the work of Dr. Tamagagi, who is a Canadian. And this was a model that took into factor certainly tobacco use, but also age and a number of other factors. We're going to look at those to really define where that kind of 1.5% risk over 6 years comes out. Why did we pick here? The survival curve here, we see this is from that national lung screening trial, that after the 6-year point in time, there is a consistent benefit to screening with CAT scans. Now, on the other side, if your 6-year risk is 0.64% or less, there really doesn't seem to be any benefit to screening. So that's why you can refer somebody for screening, but they may actually get turned down because it's really looking at that risk-benefit ratio. So the other factors that get looked at in the risk prediction model are the race or ethnicity. Indigenous Canadians and Black Canadians are more likely to have lung cancer. The education level is used as a proxy for socioeconomic status. Patients have a lower body mass index, a family history or personal history of cancer, a diagnosis of COPD. And they look at some of the metrics around tobacco use, not just how long did you smoke, but how much did you smoke, how long have you been quit. Now, don't worry, the primary care provider does not have to figure out this risk. All you have to do is refer your patient to a program when there's one available for you. You discuss with the patient the referral, and the patient does the risk calculation. And somebody just asked, is there any difference in presentation of symptoms by gender? So not really. We do know that the incidence in women has not plateaued the same way that it has in men. And we do know that women had a peak in smoking at a time when men had already started to quit. So there's some epidemiologic difference, but they generally present in the same way. So that's a great question. So when you're actually sending your patient for screening, if they qualify based on what your cutoff is in your province, then you're going to get a report. So they could be a normal scan, and they'll recommend the annual ongoing routine or biannual screening, depending on what your program looks like. A lot of people come up with what we call these non-specific nodules. And so those patients will come with a recommendation for a repeat testing in a shorter period of time for the non-specific smaller nodules. But if the findings are suspicious for cancer, they will be automatically referred for diagnostic testing with the enhanced CT scan, and the appropriate referrals will be made. So when you're having that conversation with your patient, well, you have to take into account their overall health status. So somebody with advanced dementia or severe heart disease or something like that, and they don't have a significant life expectancy, they probably aren't the greatest patient for screening. They also have to be well enough that they'd actually be able to undergo a curative intent modality treatment, but it's not always surgery. We can use high dose radiation for patients with stage 1 cancer and cure them with radiation if they're not well enough for general anesthetic or don't have the lung capacity to allow for a safe resection or part of the lung. And also patients had to be willing to go on with the next steps. Now, patients are often terrified. Lung cancer is a very scary thing. So we try to use language that's going to be less scary for patients. And we've started calling these in Nova Scotia lung health checks. And you can look at a lot of things about the health of the lungs, including for the COPDers. You can actually get a sense of how severe that is and give them information about the potential benefit if they were to stop using tobacco now. But there are lots of guidelines around terminology to use. For instance, we should never talk to a patient about a screening test being positive or negative, because if we say it's positive, that means it's a bad thing. But they often hear positive as a positive thing and then think their test was okay. So very clear, simple language with recommendations. Of course, we have to balance risks and benefits. I already kind of talked about the harm from the radiation, which is usually not too much for a low dose CT in this older population, but there's definitely an impact on psychological distress. And patients may have to go for a lung biopsy, and then they have a pneumothorax, and they have a chest tube, and then they're in hospital, and they get a PE. So there can be major complications from the downstream testing as well. And finally, overdiagnosis. We may be picking up on some very slow growing cancers that never would have become clinically relevant. And if we had to go looking for them, we wouldn't have ever even known that they were there. So a big part of our lung cancer screening programs is smoking cessation. And I actually think that we're going to get more bang for our buck by having access to these patients, because if they're current tobacco users, the interventions to support them in smoking cessation will probably actually lead to complete prevention of cancer, but also a major improvements in terms of cardiovascular disease and other lung diseases. And so all of our current programs do have some component of smoking cessation services with a lot of really appropriate counseling, so that there's a lot of non-judgmental advice being given, because patients often have a lot of guilt and shame, and that's often why they don't want to get screened. So be like, we're here to help you, and we know it's not your fault, and quitting tobacco can be quite tough. So we're here to help you. It's really the message we try to give. So finally, just to finish up, I want to put things in the socioeconomic context. Some of the reasons for missing a diagnosis of a lung cancer patient, well, number one, they often don't have symptoms at early stages, and we may not even consider lung cancer somebody without a tobacco history. So many of my non-smokers say, I presented, over and over with a cough, and I had chest x-ray after chest x-ray and 5 courses of antibiotics, and nobody ever even thought that it could be lung cancer, which is different when you have the 75-year-old who's been smoking a pack of cigarettes a day since he was 14 comes in with that same cough that won't go away. But there are also barriers to resources. No primary care provider is an epidemic throughout the country. In our province, in some counties, you're more likely to not have a primary care provider than to have one. And I know that there's no province that's been spared this, especially in rural areas. So if you don't have someone to present to, that's a huge barrier. And there's definitely certain populations that will face inequities, most commonly with our First Nations, Inuit and Métis communities. And not only do they live in more remote locations and have less access or have had negative interactions with the healthcare system, which they want to not go back, they're actually intrinsically more likely to develop lung cancer compared to other populations in Canada. So definitely a population we're trying to focus on. We do know that patients with lower incomes and who live in rural areas are more likely to get lung cancer. We know that patients that live in those areas and are lower income are more likely to smoke cigarettes. They're more likely to be advanced when they get diagnosed. And interestingly, your income predicts your likelihood of actually getting a curative intent surgery, and all that leads to lower survivals. And the numbers are quite compelling. Here we see on the left the lower income in the orange bar. That's the number of cases per 100,000 patients. So, I mean, almost double the number of cases in lower income groups compared to higher. And then on the right, we see 3-year survival rates, and that's done by stage, again, with the lower income groups, regardless of stage, having a lower 3-year survival compared to those with higher income. So a major disparity. The other major issue that lung cancer patients are facing is stigma. There's a lot of guilt and shame around smoking. And it's not like patients don't know they shouldn't smoke. Nobody thinks that smoking is good for them. It's not like, 50, 60 years ago when that kind of knowledge wasn't out there. And a lot of people have been nagged by their kids and nagged by their partners to quit, and they want to. It's just such an addictive thing that tobacco companies have created in a cigarette. So a few seconds after they inhale, it gets to their brain. And nicotine does wonderful things for our brain. In and of itself, it's not bad at all. It's all the other crap that's in the smoke that's really dangerous. And so they internalize this guilt. And so you actually have to say that to them. It's not your fault. It's the tobacco company's fault. And it's not just the general population that can be biased and have stigma. Physicians can be as well. And I've seen so many surgeons say, unless you quit smoking, I'm not going to repair your knee, or I'm not going to fix your hernia. And sometimes unintentionally we do that, say, oh, you just got COPD. That's why you're coughing, and less likely to work that up. This was a very telling survey that was done in the US. This asked the general public if lung cancer was the fault of the patient. And if they told them the patient had smoked, over half of people said it was their fault they had cancer. And even if the patient never smoked, 10% of the population still said it was their fault. And patients internalize those beliefs. And people don't do that with other cancers. They don't say to melanoma patients, did you go to a sunbed or a tanning bed? Or they don't say to breast cancer patients, did you take hormone replacement when you had hot flashes? We don't do that for other cancers. And so trying to get rid of some of that stigma will actually lead to much better care, because it has huge implications. So along with the Lung Health Foundation, we have done this public service awareness called Stop Asking the Wrong Question. And the wrong question is, did you smoke? And our argument is it doesn't matter if somebody smoked or not. They should be treated with the same care and the same compassion as other cancer patients. And so the right question is just the same as you'd ask any other cancer patient. How are you doing? Or what can I do to help? And so we really tried to raise that awareness. And here in Nova Scotia, our Nova Scotia Lung Association, I found had a very powerful anti-stigma campaign. So just to close up, I want to show you some of the ads from that. So in a world without stigma, Simon wasn't ashamed to share his diagnosis. And so here's a guy who couldn't have the support of his friends because he was embarrassed because he had lung cancer. He wouldn't have been embarrassed if he had colon cancer or prostate cancer. In a world without stigma, Mary caught her cancer at stage 1. Here we see a little girl with her dad, and her dad has lung cancer. So in a world without stigma, Caroline wouldn't have to explain that her dad didn't smoke, because her friends say to her when they find her dad's got lung cancer, I didn't know your dad smoked. And then finally, in a world without stigma, Diane's research study wouldn't be underfunded. I've already told you that lung cancer causes more cancer deaths than breast, prostate, and colorectal cancer combined, yet the funding we get for research is just a margin of those other cancers. And because of that, there's less research into the non-tobacco causes of lung cancer. We don't know a lot about radon because we haven't been able to study it. And all those other groundbreaking research projects are being funded, but really we have to fight that as a group, and awareness is the first step. So I'm now moving on to the questions. So I think there's a couple of other questions here in the Q&A. So aside from smoking cessation, what is the most effective way to boost cancer survival? So I would definitely recommend, especially if you live in an area that is known to have high radon, to encourage people to have their houses tested for radon. It's very easy to fix if you just know it's there. And I think that can be a major contributor. Also, I mean, if patients are working in certain industries, you know, if they're a mechanic and breathing in diesel fuels all day, encourage them to use the appropriate respiratory equipment, or painters, or different chemicals, those types of things. Also, to have patients go for screening when they can, and just the basic, you know, good things we should all do for our health. Eat more fruits and vegetables and be more physically active. Those things are very important for all cancers. How can palliative care be incorporated into the care plan? Is it effective for this population? Absolutely. I was a resident and I was at a major meeting, and they showed a survival curve. And of course, the top curve is doing better than the standard of care. And they got us to guess as residents what the intervention might be. And we said, oh, maybe it's a new chemotherapy. Maybe it's one of those brand new targeted treatments that are just coming out. It was actually early intervention with palliative care. Patients not only feel better and have better quality of life, but they actually live longer. And it's probably because they've got more people taking care of them, so they can pick up on certain symptom issues, like maybe symptoms of a DVT or a PE or a pneumonia sooner. But we're also finding that they're receiving less things like chemotherapy in the last 3 months of life, which is a marker for good care, because you're not giving them something that's helping them and maybe even harming them. The problem, of course, like so many things in Canada, is access. The palliative care docs know this literature as well as we do, but sometimes they're just so busy providing active end of life care, they don't have a lot of time to get involved with people while they're still under the care of an oncologist. And there's even variability widespread throughout my province, but I always encourage an early referral. And even if they can't follow them necessarily, they've made that connection. And palliative care can be great at helping patients define what's important to them and how they want their journey to look like. And that really helps them make the best decisions for themselves. And finally, are there plans to expand screening programs to include people who do not have a history of tobacco use? So right now, we're just trying to get the programs rolled out for the people who do have that highest risk, which is generally the 1.5% risk of lung cancer over the next 6 years. Lung cancer screening is very expensive. It's not even like a FIT test or, even mammograms. It's much more complex because you've got to read a full lung CT. And then there's all the downstream implications of, you can have another CT because you had a non-specific nodule, you need a biopsy, and then we need to build in the quality control. So we're doing it slowly but surely because it does take a lot of quality control and there's a lot of administration to make sure that patients are called back. Now, that being said, there's no evidence to screen patients who do not have that history of tobacco use because their lung cancer risk would just be too low to justify the current cost and risk to the radiation without the evidence. But there's some really amazing research going on for better ways to screen for lung cancer. And so a lot of this is happening out in British Columbia. There's a group led by Ronelle Myers, who's a respirologist out there. And they're actually studying this labeled kind of mint. It's like the kind of mint that you get at a restaurant after your supper, and you suck on it, and then they do a breath test. And there's certain kind of labeled something or other in this mint, and when they breathe it out, lung cancer patients will actually manifest that in a different way. So when we get less expensive, less risky, less invasive tests, we can actually expand that more readily to the whole population. And I think what's going to revolutionize primary care and cancer screening in general over the next years, we're starting to see the beginning of the research, but it'll probably take a solid decade or two to roll out to everyday care. We'll be actually screening for multiple cancers with blood draws. Lung cancer is one of the cancers that readily sheds its DNA into the bloodstream. So in the future, screening for multiple cancers might be just sending a vial and looking for circulating tumor DNA. You might be able to detect breast cancer and lung cancer and colorectal cancer long before there's something you can pick up radiographically. So that might be the future. And hopefully those things will be able to span everybody, including non-smokers. But for right now, we're just trying to focus on that high risk group in which there's the evidence for the survival benefit.